Well, as we've already established by the first panel, healthcare is that weird cousin. Healthcare is something that is, can it be radically changed or can it be adjusted? It's like the crazy person in the room. One of our earlier panelists said, you kind of have to live with it and humor it and change it slowly. But this panel is about disruption, and we're going to perhaps challenge that a little bit, or at least think about the best ways that things might be disrupted. Of course, saying disrupted regulated industries, in this case healthcare, is, to begin with, just a little bit problematic because we assume that radical technology innovation or disruption is something that we want and that it's held back by regulation. Otherwise, these things would just naturally arise, like some gift from the gods. But while there's reason to think so, it's also worth considering reasons why something is regulated and what the good parts of that regulation are so that those things are preserved. For example, I think the rules that protect drug safety or patient privacy aren't things people want to rip apart, although you might have disruption which unintentionally or intentionally does tweak those in an ultimately negative way. So you've got to be a little bit careful about that. On the other hand, regulation is frequently hardened over time because it's written against a certain technology system that then changes. Many of the regulations you find in health having to do with IT anyway speak to an IT system that existed in the 1970s when the laws were written. And ultimately, the regulation is also, while a form of protection, it's a form of protection of incumbent players and practices that need to be re-examined. So, in this panel, we hope to make a little bit of progress towards defining a healthy position for disruption and healthcare. And I'll be joined in this by Vivek Wadhwa of Stanford, Singularity University, and general gadfly about the technology world. And Christensen from Clayton, well, we've done these introductions, and Marina at the end. I wanted to start by trying to frame this a little bit broadly so that we're sort of on the same page about what the regulation is and what we're trying to disrupt here. And I think the way to address that is to talk about what is the chief area of healthcare regulation that we're talking about here. That is to say, who is the customer or the end user that we're targeting? If we talk about payments transformation through disruption, is that the government? Is that the insurers? Is that the individual? If it's about health delivery, are we talking about a hospital system and a clinic system? If it's about patient security and health, is it ultimately about disrupting a consumer system? So let's go down the line addressing what you think of as the system and the parts that are most regulated and in need of change, and talk about your own relationship to that, okay?
Should I go first?
Yeah, please.
You know, I'm looking at the big picture, and I see a wave of disruption that no one understands and no government can control. So Quentin's question is, what do I see needing disruption or will be disrupted? Payments is the easy thing, but that's nothing. The actual...
back up there. Why is payments nothing? Because that's...
Because everything else that's going to happen is going to make payments less relevant. We're talking about the entire healthcare industry becoming an app, becoming a technology. Everything from detecting your vital signs to now being able to read your body metrics, being able to detect disease, being able to sequence your genome. Everything which is private about us is now deciphered, decoded with the genome sequencing and with these sensor-based devices. And we have no security whatsoever. So all of the regulations about protecting our personal data and so on, out the door. And then who can deal with these data? Now that the genome sequencing costs $1,000 right now, we're headed to $100, $50, $25. We'll have iPhone cases that do complete genome sequences 5 to 7 years from now. It's almost certain at the way things are moving, which means that we can now start shaking hands with someone, looking at the glass, taking the glass that they just drank from and sequencing their genome and finding out everything about them.
Creeping me out here,
No, but this is the future we're headed into, and this the near future. And then what you do is that you take this data, you can have app developers in Silicon Valley now analyzing them and coming up with new...
So relative to payments anyway, you're saying that a system of payments that pre-existed inside that technology world will just arise and take over
So,
the existing payment
you know,
system
for
because
example,
the
here's the
technology
thing.
will.
If EKG, I have the live core heart monitor on this thing. It cost me $0 to get an EKG. If I went to the cardiologist, he would charge my the medical company about $800 or so and bill me $300. So this is $0. I can now get EKG tests for $0. I can upload my EKG to the service that LiveCore provides, and for $5, I have a cardiologist read it.
Right.
So this entire concept of having to go to a cardiologist and traditional medical testing has been upended already.
So
it's
you're
commercially
positing that
available
there's
today.
a cardiologist who's okay with getting $5 to read a chart?
Well, ask Dave Albert. I mean, yeah, that's what the business model of LiveCore is.
That's a
It's done. And at $5 is probably too much because
that's software reading it in that
there
case.
are
That's not a
several
person.
companies in India who I met who have built this as well. They didn't have to worry about going through FDA approvals. And what's more, they're building the AI apps to analyze your EKGs. And they're talking about having it for free. They'll just prescribe you some medications and make money on the medications they send you.
Back on the planet, Anne, how far down the road?
This is here. This is now. I mean, I'm not talking about science fiction.
You've talked.
Fair enough. Well, I want to take a little step back and just talk about innovation and disruptive innovation. A lot of people are not real shocked to find out that at the Institute for Disruptive Innovation, we talk disruption all day long. But here, especially in Silicon Valley and San Francisco, the Bay Area generally, we want to stick the name disruptive on everything that is fun, new, innovative, shiny,
It's
trendy,
inherently positive here.
anything.
Yeah.
It is.
And it's good. and we
But
should
not
welcome
all
it.
innovation is actually disruptive. And so I think we want to be careful as we talk about disrupting the system about what disruptive innovation really is. And so there are a lot of things that are innovative, new, breakthrough, big innovations that are actually, we would call them sustaining in nature because they're better than what's already out there. They're new technology, but fundamentally they're often more expensive.
Can you give us an example of what a non-disruptive innovation might be?
Sure. So, most of our Apple products, frankly, but they are newer and better and more sophisticated devices, computers. The new
so
new
like
iPhones,
the
things
iPod
like that.
is basically
kind
an
of next
MP3
generation
player with
products.
a better user interface.
Yeah.
Okay.
Next generation products are often sustaining in nature. Disruptive products are characterized by technologies that make things, products, services more affordable and more accessible. And one of the tricky things about disrupting in regulated industries is that coming up with less good, more affordable products and services is really restricted by regulation. So back to your original question about kind of what is the healthcare industry, right now it is a system of kind of misaligned incentives, largely controlled by the government, love it or hate it, that is really restricting our ability to disruptively innovate. There's a lot of places to go up, new technologies, new treatments for health problems, but to disruptively come in at the low end of the market and make products and services more acceptable, harder to do.
Well, at first pass, that sounds somewhat contradictory because you're saying sustaining innovation suggests you sort of get inside their bubble. Your world can be incrementally changed. You're also saying their world is dysfunctional. Is there some way to harmonize those two by saying we can create sustaining innovation that harmonizes this system?
It's possible. I haven't seen it yet, but it's possible.
Okay. Marina, how do you see this system?
So I'm excited about a lot of technologies. We always tend to focus on technologies, and I always see technologies as kind of enablers. And when I look at what is the nature of this change or disruption, whatever name you give it, I think at a meta level, it's about changing who is the authority in health, because that's what it is. We have new authorities coming into play. There was just a study done by, I think, University of Indiana that compared treatment outcomes for 500 patients, and they put a lot of data, and they placed doctors against AIs, a lot of doctors' opinions against AI, and they put all this data about the conditions and symptoms and all kinds of things, and what was the treatment recommended. And by 40%, the AI basically suggested better treatment and diagnosed better. So we have these new authorities. I look at things like the Parkinson's Voice Initiative that basically can listen to your voice on the phone and can detect early signs of Parkinson's. So these are kind of these new authorities, this data, these health apps, all of this. And what's being disrupted is who is the authority and who do I listen to in this whole environment. And while we have these new authorities that are coming in, apps and data and information and all of that and AI, what we haven't figured out, for example, if I think about, okay, so I have the software listening to my conversation on the phone and it detects I have early signs of Parkinson's, how do you communicate that? Do you send an email to somebody and say, you have early signs of Parkinson's? Do you ping them? What do we do? What's the interaction? And there's kind of this new role, I think, for people in the medical profession that they're not actually being trained for, which is the narrative creation, because how we communicate this data, whether we give people this information as technical news versus something else, is very different. So I think there is a kind of a shift in authority, and there's need for kind of new skills and new interaction modes with all of these technologies and all of this data.
Wouldn't that circle into the training and, well, the creation in general of physicians? Because typically these are people who are educated a very long time, and they tend to be high achieving, they tend to be very strong egos, and you're telling them to defer to an AI system.
Or work with an AI system and learn a different skill, which is how do you create a narrative that works for you, the person you're working with.
And also in terms of patient trust, patients like looking other humans in the eye.
Absolutely.
They don't want some computer-driven thing because they think they're unique. Yeah.
Some patients and
right.
some patients, I think that's
but
kind of changing.
But typically for a sort of positive experience,
yeah.
people feel looked at.
Absolutely. And I think that a lot of physicians are not trained for that. In another study that I really like, where they listened in on conversations between patients with cancer and their oncologist, they found that only 20% of conversations were relevant to what the patient was telling the person. So the patient was telling the oncologist, I'm scared, and the response was, let me look at your labs. You know, that's not a good human response, right? No. But that's what a lot of physicians
That's a
trained.
human that's been trained to act like a machine.
Yeah. Okay, so that's where retraining comes in. And unfortunately, that's not part of a lot of medical school training. That's not part of a lot of nursing training, well, more nursing training. But it's kind of retraining of what is that role is. When you have that AI, when you have these technologies, they're better at processing data and computational tasks. We know that. The technologies are better than that. Then we have to really find a new role for humans in that interaction.
So to synthesize what all three of you are saying just a little bit, and I really didn't mean you're leaving the planet. I totally agree with you that a lot of sensor data is going to be incorporated. There's just many, many interests in creating that. There will be these new systems of information gathering and new systems of information analysis, which will, because they are businesses, appear somehow inside the current economic system, but also shifted over time. Probably, if it's through tech, by crushing prices, because that's what tech does. And there will be incentives that make doctors somehow happy with this, or insurance companies happy with this. What are the sticking points to getting there?
Clayton, before you get there,
sure.
You're assuming that everything revolves around the United States, that there's a barrier here and we're the center of the universe. We're not. The technologies I'm talking about are global. And the voice recognition that she talked about can be done in any country in the world.
Yeah.
And those emails can come from anywhere. So the FDA is no longer the prime authority on innovation.
Right.
So if it doesn't happen here, it'll happen somewhere else, and we'll be left behind. And we'll still be using those technologies because we can go to we can dial into a Guatemala-based AI as well as we can a California-based AI.
Well, then it'll end up a little bit like Bitcoin, which is right now, very attractive to elites at the highest level in the Silicon Valley, and sort of attractive to people in dysfunctional currency systems in the third world. And we'll have some sort of mirror of that, where this technology will appeal to people who can't access healthcare very well, and people who can afford to travel to other countries and get cheaper.
That's billions of people. We're talking about 3 or 4 billion people now benefiting from this technology, and us 100 million people being in our own shells, cutting ourselves off from it. We lose.
But we know that, and Anne knows it probably a lot better than most, which is, yes, a lot of innovation comes in areas where there is no established infrastructure. So you don't need to break something and establish something new.
Right.
So a lot of innovation comes out of that, or something is just dysfunctional and it's not working, and that's the only patch up that you can have. So yeah, we're going to be seeing a lot of this innovation, not necessarily in the US.
But I think, I mean, we're still trying to be successful with healthcare in the US, so I think it begs a lot of questions for us in terms of, our regulatory environment. And we don't see, I wish I could rattle off a bunch of success stories of great tech that has beaten our regulatory problems. But right now we only have a few kind of examples of what we do about this. Ideally, we could, well, take a step back. So you see it in a few places. You see, for example, retail clinics have exploded all over the United States. And those started in states like Minnesota, where nurse practitioners had a little more autonomy, according to local regulations, to be able to write prescriptions. And for a very limited menu of medical problems that we understand very well, I can stick a Q-tip down your throat and figure out whether or not you actually have strep throat, and if so, prescribe antibiotics. Very straightforward. And as retail clinics prove that they could be successful and actually provide good, convenient healthcare without hurting people, which is an important part of the conversation, then you could actually begin to change the regulations in other states that have allowed the proliferation of retail clinics. And so finding opportunities kind of at the edges, not hurting people is important, but at the edges of kind of beyond the limits of regulation or beyond the reach of regulation, and being able to prove that something works, has worked. You see some new technologies being deployed within integrated systems where a payer and provider like Kaiser are aligned and can actually work around some of the payment restrictions and say, well, actually, if a nurse practitioner is just as qualified as a PA to do this procedure, we'll have the more affordable PA provide the procedure, and they can actually make that decision, whereas in situations where payers and providers are not part of the same system, a lot of the providers are really restricted in what they can do by how they can get paid. And I think that payment thing, sorry.
No, go ahead.
I think the payment question is what's really limiting us, is right now we get healthcare where we can get it paid for. And with a lot of technology and kind of changes in the healthcare system happening outside of our country, because we regulate a lot away from us, a lot of the opportunities seem to be emerging internationally. But then we have limited control and understanding of the quality. And so I think that begs a really interesting question for us, is how much do we want to let go of?
It'll be higher quality, as Marina said.
Yeah, and I think some of the kind of interesting stuff, and where I see some innovation happening that's encouraging, is embracing these sort of bottom-up communities of people, whether it's Quantified Self or Microbe or all these communities where people are creating bottom-up data, but instead of experts sort of treating them as that's just not scientific data, they're embracing it and working with those communities and participating and taking that data in. So you've got these experts and non-experts working together in some interesting way, and you're getting some interesting results, and you're interesting sort of, sometimes there are referral systems and other kinds of things that are happening kind of at the intersection of bottom-up and expertise.
For many people, the larger narrative this takes place in is, yeah, it's a dysfunctional system in the US, but it's also the flywheel for a lot of medical knowledge, because it's got these great research hospitals, it does all this drug discovery work, it invents these machines, and that's kind of predicated on having this very expensive healthcare system.
That's the past, my friend.
That's
the
where
past.
I was going. Like, do you think that just goes away, and do you think the US stops being a center of innovation and that kind of doesn't matter because innovation happens everywhere? Everybody, jump ball.
Jump in. I don't think I just think that that net of innovation is expanding. So I think US looked here at Silicon Valley. There's a lot of innovation that's coming out of here. It may not necessarily be used here. It may be used in other places and be adopted and diffused in other places. But I don't think that US innovation is not going to be happening here. I think that but it's also going to be happening in other places.
Yeah, I've been traveling the world and watching these advances. I'm blown away with some of the technologies I've seen abroad. For example, in New Delhi, when I was there in January, There's this American returned doctor, Kanav Kohli, who essentially figured out that he could take the same medical devices we have here, buy the components directly from China, the sensors directly from China, set up his own circuit board, and he's built 31 different tests in one device, which the entire setup costs $600. He can do everything from the EKGs, heart rhythms, detect for malaria. I mean, disease after disease he can detect for. $600. It's tested in 26 different regions in India. It's in production. It's in use in 26 different regions of India today. $600 device, which would probably encapsulate $200,000 or $300,000 worth of medical equipment if we bought it individually. Happened in India, and now he's going to build the next generation, or we'll have other entrepreneurs in India building the next AI-based tools. The US has become irrelevant. He's getting it directly from China.
So I think the limiting factor, I think, is not just the innovations. I think the US will continue to be innovative. I think there's incredible technology emerging all over the world, but there's a lot of really great innovations that are made technology and healthcare more affordable, and certainly in the process of which more accessible, but they have failed in getting traction in the US because they don't get reimbursed. And fundamentally,
US does not matter anymore. Sorry to say that.
Let's just, let me pull her. Raise your hand if you are associated with a medical technology business. Okay. No, keep it up. Everybody keep their hand up. Now, drop your hand if you're not primarily targeting the US market. Don't see a lot going down, but maybe that's a bad sample. In this room, they still consider the US the primary target. I
understand that, but this is why I'm saying that things have changed so rapidly over the last year or two. I'm not talking about going back 5 or 10 years. I'm talking about the last year or two, that costs have dropped, innovation has globalized, and the same technologies are being built worldwide. This blew my mind. When I was in Delhi, I literally tweeted, I'm looking for companies doing medical device work. I was flooded with responses, and I saw as many of them as I could, completely blown away. I used to think that this AliveCore thing was the hottest medical device I'd seen, until a number of startups in New Delhi started telling me that they've got better, cheaper monitors than this.
And just free associating, how hard would it be for a foreign developed system from an unregulated market be to enter the US healthcare system in a mainstream way?
I mean, it's almost impossible. It depends on what you're talking about, right? If you're talking about a $5 device, people might pay out of pocket if it serves a purpose that they actually are looking for. In a lot of cases, what you're talking about is things that you want hospitals to buy or payers to reimburse for.
Right.
And in the near term, the US may not matter in the long term.
$5 devices,
but
no one will care.
In the near term, with devices that are hundreds of dollars and thousands of dollars, that gets no traction, or it gets forced into a CPT code where you're charging a different, a different reimbursement rate.
So to go to the classic, somewhat
the
clumsy metaphor, it's like little redwoods that grow up around the big one and eventually just the big one.
I mean, there's a lot of great devices that are cheap that we pay through the nose for. Sorry, go ahead.
Yeah, and I think what Vivek's saying is worth considering, which is, we've thought of health as a large market. It really changes the economic equation if you think of of health as just a feature on your phone
it's become an app. Health is becoming an app.
App, exactly. Yeah. And that's a very different economic proposition.
Right, and it's also, as complex as health is, it's starting to be seen in this larger context. I was just talking to somebody from Intel who's over in China looking at how people use technology there. And if you are middle class or above in Shanghai now, part of your home technology is an air quality measurement, which is a pretty good thing to stay on top of if you're in Shanghai.
One thing we haven't talked about, and I think we haven't cracked that with all the tech and all the devices, behavior change is really hard. And
habit change.
Habit change is very hard. And the other thing that we haven't cracked, increasingly, we realize that health is not just an individual story. It's a communal story. Where you live, what environment you live in, your food, your stress level, all these things. So it's not just about the individual. And if you look at some of what Esther Dyson started doing with these 5 healthy communities, interventions at that level, and I'm not sure how, I'm sure at the city level people are thinking about it, but it's not about apps. It's something else. It's about a much larger system and interventions at that level.
Okay. I've just got about 10 minutes left, so I want to take some questions from the audience. this is an interesting one. What does disrupted drug discovery look like? Regulations didn't arise for regulation's sake. Molecules need to be tested on humans. How would pharma be disrupted?
Data is going to amazingly disrupt the testing industry like you won't believe. Because right now we do limited clinical trials. You have a few hundred people typically being tested. Imagine getting millions of people. Imagine having the sensors monitoring them 24/7 and now being able to do big data analysis about what medication does work, what doesn't work, side effects, long-term impact, and now be able to correlate that with their genome data. And now, really build sophisticated apps which give you real information, not the crap that we have right now.
Okay, I'm going to lump a couple, the crap we have now. That's a term of art. I'm going to lump a couple of these together now because, we're talking about observing behavior essentially and associating that with medical conditions. But, when the rubber hits the road, let's talk about this in the context of a broken arm or heart surgery or something people associate with real medical care. What does that look like? Because that isn't cheap and easy. That's people, machines, critical timing. What kind of disruption takes place in those contexts?
I would say those are actually some of the last disruptions to happen. There's a lot of kind of lower hanging fruit problems, but fundamentally, if your arm is broken or your appendix has burst, you need a clinician to be there to, And so in terms of, I have I need a prescription today, I need an antibiotic, I have, day-to-day clinical problems, those will get disrupted a lot sooner.
We will be preventing disease. We'll go to true health care versus sick care, which is what we have right now.
But people will still fall down.
They still fall down. But we do have a lot more robots that are involved in surgery and all of that. But I agree that if you need your arm reset, maybe robots
that doesn't
will
change.
Be doing.
Yeah,
that
there's no
change.
bot that's going to. We're not making robots that set your arm.
At least not now. I don't know. Maybe somebody
never know.
Someday,
Bionic Enhancements, my
20
friend.
years, right? Bionic Enhancements, right?
Go to Exobionics down the road and check them out.
Maybe we'll have sensors everywhere that will prevent you from falling ever. I don't know.
Stabilization system. That's
Doesn't
an idea
sound
for
like
the entrepreneurs.
I don't want to live in a world that constrained. Props to the person who invented this term. Simple disruption, both physical and digital medical tourism. Digital medical tourism, I like that idea.
That's telemedicine available today. You can get advice from doctors all over the world today for practically nothing on demand. If you're sick, rather than having to take your child to the doctor and get them more sick, you can go online right now and have them advise you immediately, today.
To the extent there is a crisis in healthcare, though, isn't it frequently a crisis in human behavior? Take the stairs more, put down the donut, right? How do you change that?
That's
you
hard.
have apps
That's really hard.
You have
really
apps that
hard.
monitor you and that advise you on improving your habits.
But that's...
I think it's actually a really interesting question. We've got a lot of bright minds in this room. One of the things that we've been working on wellness programs and talking prevention for a long time, but one of the things that we fundamentally don't understand is what motivates people. And we target wellness programs and staying healthy and taking care of yourself. We talk about it like it's important, but fundamentally, day to day, a lot of people just won't take that responsibility. And so if someone can figure out a business model where we get into people's heads and understand a little better what motivates them and create a business model where we're actually aligning with people's jobs to be done, so to speak.
I've got two friends over there who are doing exactly that.
But here's the thing.
Who are you? I'd love to meet you.
I think we always place the burden on the individual. So we need to exercise more. We need to eat healthy. We need to do this and that. We don't need to sit as much. But the reality is we've created conditions that we're surrounded by unhealthy food, that it makes it really hard to pick healthy food.
We need an app that says, stop staring at your phone.
Our lifestyles are such that we're sitting all the time. And we have economic incentives for creating those unhealthy environments. And until you change that, we're placing all the burden on the individual. And it's, as much as I say, yes, individual responsibility is important, I think there's a larger system in play about our food production and what incentives are in the ag business and all the surrounding, how we create our urban environments, how we work and our lifestyles at work. That's a much larger system, and it's a very difficult system to tackle.
We need to behave more nobly as a culture.
No, we need
Well, in a
to
sense,
change
yes.
incentives.
Yeah.
We could change economics incentives so we don't produce corn.
Incentives and habits.
And habits both.
Yep.
Is this something you address, Anne, at your center?
Well, certainly. Kind of the point that I was, I think, not making very clearly earlier, just we all have jobs to be done, and fundamentally, just we had things that we want to accomplish. And most of us don't think about our health very much until we have an acute event, we're sick, and we actually need health care. But, you know, there is an extensive amount of literature that talks about kind of these problems of taking care of ourselves, acting more nobly, to your point. But no one's really figured out a business model that gets to us early enough that changes the incentives for us.
Okay.
We know we should act better, but we don't. So we got to do something different.
That's a human tragedy. Circling back, a doctor asks about AI results, blood test results, X-ray results. As a doctor, I had tons of communication. It is critical to doctor-patient relationships. So talk about how...
I'm going to take this doctor on because the doctor really doesn't know the patient. The doctor typically takes a few handwritten notes and sees dozens of patients a day. There's no way he or she can remember all the information about the patient. There's no way the doctor can analyze all the data that's now available.
I think you're misinterpreting his question.
Right.
You know, really, to a patient, that human moment is a critical part. You know, you can sort of go, boy, I'm eating a lot of sugary cereal.
I tell you, I'd rather not get sick rather than have to see a
doctor says,
doctor.
man, you're going to die. You got to stop eating the sugary cereal.
I would trust an AI over a doctor any day.
Raise your hand if you'd trust an AI over a doctor.
Look at that, an enlightened audience. They're getting it. They're understanding where it's headed.
Now, I asked that question.
The AI has perfect knowledge. It monitors you 24/7. The doctor sees you every time you decide you're going to make an appointment and then wait in line and then go through all the hassles of seeing the doctor.
Raise your hand. Wait. I was making a different point. Raise your hand if you trust an AI system over talking to a physician.
Today, move forward 5 years. Move forward 5 years.
Dial it down. I'm talking.
See, I'm looking forward a little bit.
Raise your hand if you would trust an AI system over a doctor with whom you have a relationship. Yeah, not a personal relationship.
But here's the thing.
No. Generally, it cuts younger. Vivek has a point. Like, over time, that will become a more pervasive point of view.
I'm saying within the next 5 years or so.
Yeah.
Not today.
The people in the room who raised their hands were generally younger than the rest of the room, I'd say.
I wasn't.
You were.
They're seeing the progression of technology.
Yeah, but you're a convert.
I'm a futurist.
You're a true believer. I'm talking about general America.
I think what's important here is that, and this is why at the Institute we talk about computational literacy. You actually need to become, and this is something that is just for your life, not for your job or anything, but we're increasingly surrounded by data, and we don't have a lot of computational literacy and statistical literacy in the population. So if you're a highly educated person who can interact with data and understand what the data tells you, of course, I will trust the AI anytime. I also have a network of other people who are sophisticated and understand data and can provide me with advice, but it's not evenly distributed in the population. And if you don't interact with data and you don't know probabilities and and we see it all the time, every day, that people don't know how to interact with data. So I think we may be entering this phase of where some of the population, yes, they're going to rely increasingly on...
Marina, even doctors don't know. The doctors went to medical school 20, 30, 40 years ago. They're not up to date. They don't have all this information.
I don't know it either. Okay.
Yeah. I got to cut that one off because we are under the clock, and I did want to raise this question as well. And I'm sorry we don't have more time to develop it, but let's talk a little bit about the ethical, moral, legal hazards of this world we're creating and what kind of regulation would be helpful inside of it. Because you're saying, you know, it's global, the train's left the station, we're all going to go, this is what's happening. But what are the hazards in that world?
Well, I was just working with a foundation in New York, and somebody said, you know, I look at the future as like an elephant. You know it's coming, it's just going to be there, so can we shape the path, or can we create some barriers? So I do think like privacy is a big issue, and I think it's going to be difficult to resolve, and I think that it's inevitable that privacy issues are going to be created, and I don't believe that people who say forget about privacy, you just have to learn to live in this world of open data. I don't think that's the way it's going to go. I think we need to focus on some resolution of that issue, and I do think that that's where the government can take a role. That's just one of the areas.
I'd say another one that is also fairly obvious, of course, is safety, and that what emerges, part of what keeps a lot of people seeing their doctors in the U.S., even if technology provides cheaper options, is that that they've gone to medical school and they have a certified certain amount of training. As especially in the near term, as a lot of these technologies emerge, we just don't know what we're getting. And as companies continue to exist, there is, records of safety and things like that that'll give us confidence. But I think there's an important role for our government and maybe an international regulatory body to be thoughtful about the kinds of care we're receiving.
I see an exponential gap developing in laws and ethics. Laws are codified ethics. Ethics really are based on social consensus. We haven't even decided what's good or bad. Most people don't even know these advances that are happening. They don't know that they can get telemedicine today. They don't know they can get AI-based, there will soon be AI-based physicians. They don't know all these sensor devices that are being built worldwide. So there's huge lack of understanding about these technologies. So no social consensus, no ethical values established yet, therefore no laws. We're basically headed into a very uncertain future.
I'd point to one more hazard, which would be tracking and identification through other means. If I can shake somebody's hand and tell their medical history, it's easy to create a scenario where I could capture their exhalation and get a sense of where they were that day.
Absolutely.
Things like that, and
your phone already knows that. I mean, so does the NSA, and God knows how many other agencies.
On that cheerful note, an app that defeats that. There's another business. I wish we had more time. It's a fantastic panel. Thank you all very much.